Hi, Mike Gibson, Ted Feldman coming to you live from SCAI 2016. Ted, talk to us about the state of the art in mitral valve replacement and repair.
Well, you have already given the balance.
The balance, the tension here.
And it is just, this is exactly it.
Yes.
It's up and down. We have now a decade of development of mitral valve repair technologies. Several that are CE approved in Europe. Far and away, MitraClip with the vast experience, tens of thousands of patients.
Pretty vast at this point.
And pretty positive.
Yes.
Which
is pretty amazing for it. It is a first generation device, am I not right? Or is it tweaked second generation?
No, you just hit a very interesting point, and that is the MitraClip device that has been in clinical practice all this time, for all practical purposes, is unchanged from what was used in the first in human experience.
Pretty amazing for a first in man device, or first generation device.
It says two things. The device itself really works, and the delivery system at this point is kind of homemade and pretty old, and we'll look forward to improvements going forward.
Yeah. Sometimes we do pretty well on the first shot at something.
Well, this was an amazing technology to be this successful based on such an early technology. But that said, over 30,000 patients treated. The Cardiac Dimensions Carillon was the second one approved in Europe. Hundreds of patients treated. And the Valtech Cardioband and the Mitral Line Pledget system were both recently CE approved and have some uptake. Certainly Cardioband has some uptake. And we know kind of what to expect from these technologies very broadly as a group. We can predictably reduce MR, have residual MR in a fair proportion of patients, and despite the residual MR, have predictable clinical improvement. Favorable LV remodeling, reduced hospitalizations, no survival data, but some really important clinical outcomes.
Is that residual MR, is it constant over time or does it increase? What happens with that residual MR?
Well, that is also a absolutely on-target question. When we started doing MitraClip, our surgical colleagues said, without an annuloplasty, these patients are going to have recurrent MR guaranteed.
Interesting, yeah.
So we now have a 5-year prospective published data set from the first big eValve trial, the Everest 2 randomized trial. Core labs, high level of follow-up, and there is absolutely no change in MR over 5 years.
That's amazing.
The patients that failed early.
Yes.
All the way out to 5 years, we see completely stable left ventricular remodeling. So the volumes go down in the first year and then they stay there. And the big surprise is that the annular dimensions are from the day the clip was put on until the 5-year mark stable.
Yeah.
So we can speculate that the clip forms this tissue bridge and may stabilize the annulus.
Really? That's fascinating. That's interesting.
So it's different than surgery.
Yeah.
So that's a key point also. So the other big lesson is that we have all these patients with residual MR, and that's also a lesson from surgery historically has been if you leave MR, you get bad results.
Right.
And this is different. Very clearly.
Interesting.
So on that background, that we get some LV remodeling, definitely have patients feeling better. Now comes catheter-based valve replacement for the mitral valve. Unequivocally fueled by the idea that look at TAVR, mitral valves next.
Right.
You know,
just working our way around.
Yeah. Story over.
Yeah, right.
Not really. Not quite so fast. Yeah. So many challenges with the mitral valve. We've got 3 mitral replacement technologies that were acquired by large U.S. companies.
How many were there? I heard there was 30 to 40 of these little companies turning in the space, and it's consolidated now to 3 front runners?
There are 3 that have been acquired by large companies. There are easily 25 more out there that are in various stages of development. But yeah, we had Edwards, Medtronic, and Abbott spend over $1 billion
Wow.
on 3 companies.
That's a lot of money.
So
That's a big bet.
not surprisingly, that heats up the field
Yes.
if it wasn't hot enough already.
Sure.
And that said, if you look at all the various mitral technologies, even beyond those 3, the total number of patients implanted to date is still under 100.
Wow. That's a big bet for 100 patients.
Well, at the time of the acquisition, it was probably half that.
Yeah.
So it is a big bet. It does reflect a conviction that these therapies will have a valuable place. Mm-hmm. But I think it is fair to say that we're not sure which ones will really emerge as
Sure.
the best therapies in that class. And the other challenge with mitral replacement is we're in the phase now of working out the technology. So it's mostly transapical.
Right.
It's going to take a while to get to a predictable transeptal implant. Mm-hmm. Anchoring is a problem. Mm-hmm. Paravalvular leak is a little bit of a problem. LV outflow tract obstruction, this big prosthesis sticking into the LVOT,
Ouch.
very big problem. Because many of these patients are severe MR, little ventricle.
Yeah. Yeah, well, they've remodeled that way, yeah.
And then fixation. Yeah. There are a lot of issues here. So it's going to now.
What's going to be the comparator? I mean, when you try and go for your pivotal trials.
So this is exactly what makes this even more complicated. So we're talking about first a technology development that's just beginning.
Right.
Unlike aortic stenosis, where we know if you have a device that works, the clinical side of it will be great. You replace the aortic valve. We've got decades of surgery. Everybody gets better. Mm-hmm. Easy. Mm-hmm. We have no such history with the mitral valve. Mm-hmm. Mm-hmm. So we know very well that we can replace the mitral valve, and some people respond and some people don't. It's a disease of the LV. Is treating the valve enough? Is the insult of surgery why some mitral valve surgical populations don't do so well? And none of that has really been prospectively addressed. So it's not as though it's really a 2-stage development, but there are 2 elements to the mitral development that have to both work before this is a clinical entity. So my personal view is that replacement is going to obviously have a huge role. It's not going to happen right away, and given the greater invasiveness, the issues of thrombosis, that repair, in the very least, will have a role for quite a while.
I agree. Ted, thanks for sharing all your valuable knowledge. One of my heroes, great operator. Thanks for joining us here today.
Great pleasure.
Thanks for all you do for SCAI, and thanks to all of you for joining us here live from SCAI 2016.